We've got a pretty packed roadmap ahead of us today. We'll be hitting basic polyp types, jumping into genetic polyp syndromes, tracking the exact adenoma-carcinoma sequence, exploring clinical presentation, and finally wrapping up with screening, workup, staging, and prognosis. Sound good? Let's get to it.
Part 1. Polyp types. We really have to start at the baseline here, with the most common, lowest-risk polyps you'll actually encounter in the bowel.
So there's a really crucial difference between these two baseline benign polyps. Inflammatory pseudopolyps are strongly associated with ulcerative colitis. Now, the pseudopolyps themselves aren't actually premalignant, but, and this is a big but, the surrounding inflamed bowel tissue definitely carries a high cancer risk. On the flip side, we have hyperplastic polyps. These are literally the most common type of colorectal polyp overall, usually popping up in patients in their 60s or 70s. They form simply because the epithelial cells just stop shedding normally, which leads to this pileup of goblet cells. The main takeaway here, neither of these two types will directly turn into cancer.
Moving on to Part 2. Polyp syndromes. This is where genetics really come into play. We're breaking these down into hamartomatomus and adenomatomus groups so you don't get lost in all the terminology.
Okay, to really grasp the hamartomatous syndromes, you absolutely have to contrast Peutz-Jeghers with Cowden syndrome. Peutz-Jeghers is an autosomal dominant condition linked to the STK11 or LKB1 gene on chromosome 19. It's famous for polyps with this distinct arborizing or tree-like pattern. Clinically, you'll see perioral melanosis, basically dark spots right around the mouth. Now, while these polyps aren't premalignant themselves, they act as lead points for bowel obstruction. Plus, this syndrome carries a staggering 100 times greater risk of pancreatic cancer. No joke. Contrast that with Cowden syndrome, driven by the PTN gene. The polyps are still benign, but this syndrome causes skin lesions like lipomas and dramatically cranks up the risk for thyroid, breast, and uterine cancers.
Aside from those heavy hitters, there are a few other rapid-fire hamartomatosis syndromes you really need to keep in your back pocket. Juvenile polyposis, linked to the SMAD4 mutation, presents with anywhere from 3 to 100 polyps, and yes, it actually does increase cancer risk. Then there's Banyan, Riley, Ruvalcaba. This one has a very unique triad: macrocephaly, hypothyroidism, and penile pigmentation. Finally, Cronkite-Candida syndrome pairs non-premalignant gastrointestinal polyps with ectodermal issues like alopecia. Seriously, memorize these unique physical traits. They're absolute dead giveaways on exams.
All right, shifting gears to the adenomatous syndromes, the ones with true malignant potential. You have to contrast FAP with Lynch syndrome. It's an absolute must. Familiar adenomatous polyposis, or FAP, is a mutation in the APC gene on chromosome 5. These patients develop over 100 polyps, meaning tumor initiation is just massively accelerated. Without surgically removing the colon, there is a literal 100% chance they will develop cancer. Then we have HNPCC, better known as Lynch syndrome. This is caused by defects in mismatch repair genes like MSH2 and MLH1. The fascinating part here? There's no massive polyp buildup at first. Instead, tumor progression is what's accelerated. Once a tumor starts, it moves incredibly fast, carrying a 70 to 80% lifetime risk of colorectal cancer.
To truly master this section, you've got to lock down the specific syndrome variants. If a patient has FAP but also shows up with bone tumors like osteomas or soft tissue desmoid tumors on their abdomen, boom, think Gardner syndrome immediately. What if they have FAP paired with central nervous system tumors like a glioblastoma in an adult or a medulloblastoma in a kid? That's Turcott syndrome. And if they present with a variant of HNPCC that includes sebaceous gland tumors or keratoacanthomas on the skin, you're looking at Muir-Torre syndrome.
Part 3. The adenoma-carcinoma sequence. We've got the genetics down. Now let's zoom in on the exact biological steps that turn a benign little growth into a deadly tumor.
But hey, before we look at the microscopic genetics, we have to ask a really vital clinical question. When you're looking right at an adenoma through a scope, how do you visually assess the risk? Like, what actually dictates whether you can just snip it out right then and there, or if that patient is going to need major open surgery?
Well, that risk is dictated by size, quantity, microscopic structure, and shape. Villus polyps are notoriously high risk, and fun fact here, they actually secrete potassium and bicarbonate, which can cause metabolic acidosis. But the real deciding factor is shape and depth, mapped out perfectly by Haggett's classification. If a polyp is sitting up on a stalk, and the cancer is totally confined to the head or neck, so levels 1 and 2, you can safely remove it with an endoscope.
But once that cancer invades the stalk or goes below it, levels 3 and 4, you're looking at open surgery. Oh, and definitely pay attention to sessile or flat polyps. Since they don't even have a stalk, if they become malignant, they instantly skip those early levels and jump straight to a level 4 classification.
So how exactly does that polyp become malignant in the first place? To understand that, we turn to Vogelstein's famous adenoma-carcinoma sequence. It's basically a gradual accumulation of genetic hits. Step 1. The APC gene mutates, kicking off early dysplasia. Step 2. A KRAS mutation pushes it right into an intermediate adenoma. And Step 3. The final devastating hit is the loss of the p53 tumor suppressor gene, converting it into full-blown carcinoma. Just remember the simple mnemonic, AK53. A for APC, K for KRAS, and 53 for p53. That right there is the biological timeline of colon cancer.
Part 4, Clinical Presentation. Now that we know exactly how these cancers form biologically, let's talk about how they actually present in the real-world patient sitting in your exam room.
There is this stark anatomical contrast that you absolutely must understand here. Cancers on the right side of the colon behave entirely differently than cancers on the left. Right-sided lesions tend to be ulcerative. They bleed silently and continuously. Because of this, the patient usually won't even notice a change in their bowel habits until very late in the game. Instead, they just show up totally exhausted with unexplained iron deficiency anemia. Left-sided lesions, though, they grow in a ring around the tighter lumen of the descending colon. They constrict the bowel, creating this classic apple core deformity on imaging. And because of that tight constriction, left-sided cancers cause early, painful bowel obstructions in tenesmus.
So what exactly predisposes someone to these lesions? Major risk factors include alcohol, a high-fat diet packed with red meat, a history of ulcerative colitis, and previous surgeries like a ureteris sigmoid anastomosis. Oh, and selenium deficiency. On the flip side, protective factors include NSAIDs, selenium, and a high-roughage, high-fiber diet. But please, be incredibly careful with diet correlations. Test writers love to trick you into thinking that because a high-fat diet is bad, a strictly low-fat diet must be protective, right? Wrong. In reality, a low-fat diet has offered no proven risk reduction in the data. It's a classic trap, so don't fall for it.
Now, if a patient does develop a cancer, we have to worry about this biological phenomenon known as field cancerization. This perfectly explains why we don't just stop looking when we find one single tumor. See, the entire colon has been exposed to the exact same dietary toxins and carcinogens. Because of this field cancerization, roughly 4 to 5% of patients are going to have a second, synchronous tumor hiding out somewhere else in the colon at the exact same time. Which brings us right into part 5, screening and workup. Because of that risk of synchronous tumors, and really the slow progression of the AK53 sequence, our screening protocols are without a doubt our greatest weapon.
Colorectal cancer is actually one of the few cancers where screening actively, directly reduces mortality. For the average person, baseline screening starts at age 50 with a full colonoscopy, repeated every 10 years if everything looks clear. Or, if they go for a sigmoidoscopy, it's every 5 years. But for genetic risks, that timeline shifts dramatically. If a patient has a first-degree relative with a FAT mutation, we are stepping in aggressively, starting annual sigmoidoscopies at just 10 years old.
Once a cancer is suspected, this highly structured workup kicks in. The absolute gold standard for diagnosis is a full colonoscopy, using a scope that's 110 to 140 centimeters long to visualize everything from the rectum all the way up to the cecum, purely to rule out those synchronous lesions we just talked about. For general staging, a PET-CT using the 18-FDG isotope is your modality of choice. But I want you to anchor this specific exception in your mind. If the cancer's in the rectum, an MRI with an endorectal coil is strictly required to properly assess the T and N stages. Oh, and if the cancer is spread distally, the liver is by far the most common site of metastasis. Finally, part 6, staging and prognosis. This is the climax of the clinical journey, where we determine the patient's exact situation and outlook.
Before we even get into the staging criteria itself, there is a critical magic number you need to remember: 12. During surgical resection, a surgeon has to successfully remove a minimum of 12 lymph nodes to accurately complete a TNM staging for colorectal cancer. Anything less than 12, and the staging is officially considered incomplete.
As for the TNM staging itself, the criteria have had some recent updates you should know about. T-stage, which relates to the depth of tumor invasion, has a split at T4. T4A means the tumor has penetrated the visceral peritoneum, while T4B means it's actually directly invading adjacent organs. Then there's the metastasis, or M1 category, which is now split into 3 distinct levels. M1A is metastasis confined to one organ or a non-regional node. M1B is 2 or more organs, but still no peritoneal involvement. But the very second the peritoneum is involved with metastasis, it escalates straight to M1C.
So, how do we synthesize all of this into a meaningful prognosis? Well, the Duke's classification, or the modified Astler-Collar classification, flows incredibly logically. Duke's A is confined to the early mucosal and submucosal layers, giving a solid 90% 5-year survival rate. Duke's B invades into or beyond the muscle but has no lymph node involvement, dropping survival to about 60 to 70%. Duke's C is where the lymph nodes become involved, and that's where survival plummets to roughly 30%. And Duke's D is distant metastases, with survival falling below 30%. It's basically a simple descending rule of thumb. You just reduce the survival rate by roughly 30% for every deeper stage the tumor reaches.
We're going to wrap up this explainer with a somewhat provocative thought. We've just seen how a single mismatched gene in Lynch syndrome or a mutated APC gene in FAP can dictate a near-certain 100% lifetime destiny of cancer. As our understanding of the AK53 pathway and these genetic triggers accelerates, how close are we really to replacing invasive scopes entirely with simple, non-invasive genetic blood and stool panels? We might very soon be diagnosing and neutralizing these risks long before a single polyp ever has the chance to form. Thanks for joining me today, and I hope this deep dive brought some incredible clarity to a really complex topic.